Hey everyone, in this session, we're going to break down the new unified guidelines for detecting monoclonal gammopathies. And if you're a medical trainee, this is absolutely for you. We're going to give you the clear, practical playbook you need for your patients.
So, we'll tackle this in 4 parts that pretty much mirror how you think clinically. First, we'll lay out the problem. Then, we'll get into the most important step, what tests to order initially. After that, we'll see how to confirm those results, and finally, what it all means for your patient's long-term risk. All right, let's dive right in. First off, why all the fuss? I mean, why do we even need a unified guideline for this? It's because these conditions aren't just one thing. They're a whole spectrum, ranging from a totally harmless lab finding to a full-blown medical emergency.
You know, we've all been here. A patient shows up with these vague but persistent symptoms. They're tired, they've got bone pain, maybe their kidney function is off. It could be a dozen different things, right? But this is exactly why these guidelines are so critical. A monoclonal gammopathy has to be on your differential.
So what are we actually hunting for here? Well, think of monoclonal gammopathies as a whole family of disorders that have one thing in common. A single clone of plasma cells has gone rogue and is just churning out one specific type of antibody. That's the M protein. The really tricky part is this can be anything from an incidental finding to a sign of a very serious cancer like multiple myeloma.
And this chart really puts the whole challenge into perspective. I mean, just look at that huge blue slice. 58% of these cases are MGUS, which stands for monoclonal gammopathy of undetermined significance. It's often totally benign. But right next to it, you've got significant chunks from multiple myeloma and primary amyloidosis. So this is the core problem. How do we reliably pick out the dangerous players from this much, much larger pool of benign ones?
And that is exactly the problem these guidelines were designed to solve. You see, before this, labs are kind of all over the place with their testing strategies. That kind of inconsistency is flat out dangerous. It means high-risk patients could be missed entirely. The whole point here is to get everyone on the same evidence-based page. Okay, now for the most practical part of this whole talk, your initial testing playbook. If you even suspect a monoclonal gammopathy, this is precisely what you need to do. All right, lean in for this one, because this is the single most important takeaway from the entire guideline. For your initial screen, you have to, I repeat, have to order both a serum protein electrophoresis, or SPEP, and a serum free light chain assay. It's not an either-or, you need both, period. So why is ordering both so incredibly critical? Think of it like this. SPEP is a great test, but it has a massive blind spot. It can completely miss patients whose myeloma only produces free light chains, and that's up to 20% of them. So by adding the free light chain assay, you slam that diagnostic door shut, pushing the sensitivity up to nearly 100%. And here's what that looks like in practice. It's just beautifully simple. You start with your clinical suspicion, you order that 2-test panel, and the results from that one move guide everything that follows. It's designed to be clean, efficient, and to get you the right answer. Now, the guidelines are just as clear about what not to do. They strongly recommend against using the heavy/light chain or total light chain assays for your first screen. The evidence just shows they aren't sensitive enough, and you seriously risk missing a diagnosis. So just keep it simple. Stick with SEPEEP and the serum-free light chain assay. Okay, so your initial labs come back and something's flagged as abnormal. What's next? How do you confirm what you're actually dealing with? Well, the good news is the next step is very straightforward. It actually doesn't matter if the abnormality popped up on the SPEP or the free light chain ratio. The answer is the same for both. Your confirmatory test is serum immunofixation, or SIFE. That's how you lock in the finding. And there's a really good reason for this. As the guideline itself points out, SIFE is the gold standard. It does way more than just say, yep, there's an M protein. It tells you exactly what kind it is, like IgG kappa or IgA lambda. And that little detail is absolutely crucial for figuring out the patient's prognosis down the line. But what about those really high-stakes situations? Let's say you're specifically worried about AL amyloidosis. In this case, time is of the essence, and the M protein levels can be tiny, almost undetectable. Here, the guidelines say to pull out all the stops, right from the get-go. You're going to order the full panel upfront. That's SPEP, serum free light chains, serum immunofixation, and you're going to add urine immunofixation. And the data really shows why this matters so much. One key study hit a 100% detection rate for AL amyloidosis just by combining the serum tests with urine immunofixation. When you're dealing with a disease this aggressive, you just can't afford to miss anything. You've got to maximize your diagnostic power right from the start. So, you've gone through the steps, you've confirmed the diagnosis. Now what? Let's talk about the final and maybe most important piece of the puzzle, using these lab results to assess your patient's real risk and predict what might happen next. And this is really where all that workup pays off. See, it's not just about putting a name on the condition. It's about predicting the future. Especially for that huge group of MGUS patients, these lab markers are your tools to figure out their specific risk of progressing to cancer. This is what tells you who needs to be watched like a hawk and who you can genuinely reassure.
So let's start with the baseline. On average, if a patient has MGUS, their risk of it progressing to something more serious is about 1% per year. But of course, no patient is average. The lab tests we've been talking about are exactly how we pinpoint who's at a higher or lower risk than that. This table basically lays out the 4 key risk factors you need to be looking for. Think of it like a checklist. First, do they have an abnormal free light chain ratio? Second, is it an IgM isotope? That has its own specific risks. Third, is the M protein level high? We're talking above 1.5. And finally, are there other normal antibodies suppressed? The more boxes a patient checks, the higher their risk, and the more closely you need to follow them.
So, if we boil it all down, here are the 4 essential rules. Number 1, screen with both SPEP and serum free light chains, every single time. Number 2, confirm any weird result with SIFE. Number 3, if you are even thinking about AL amyloidosis, escalate immediately and order the whole panel. And finally, number 4, use all these results to stratify your patient's risk. That's what's going to guide everything you do from here on out. And that really wraps up our tour of the current guidelines. What we've talked about is the absolute best practice we have today. But, medicine never stands still. The big question on the horizon is whether these newer, ultra-sensitive techniques like mass spectrometry will eventually replace these tests and become the new gold standard. It's definitely a space we all need to watch. Thanks so much for tuning in.